In 1968, the World Health Organization published a seminal paper establishing the criteria for disease screening. The same paper also warned us that if we implement screening for a disease without good medical data, people will believe that screening saves lives. With the passage of time, this paper warned us this belief will pass from the realm of scientific knowledge to folklore. And yes, we are talking about breast cancer screening today, a topic that is as much folklore today as it was science in the past. And given its folklore status, it has not only been capitalized for profit, but also turned into a quality measure so that no one will question its status. Welcome to PCP Lens, where we journey through metrics, money, and madness. My name is Sudeep Bansal. I'm a primary care physician in Connecticut, and I run my own medical practice. In today's video, I'll take you on a journey reviewing the medical literature that not only led us to implement breast cancer screening for the entire population, but also to make it a quality measure. We will discuss that there may be some benefit, but also possibly a lot of harm. Let's dive in. The breast cancer screening quality measure specifies the percentage of women 50 to 74 years of age who had a mammogram to screen for breast cancer in the 27 months prior to the end of the measurement year. Let's break down the quality measure into its individual parts. First is the denominator, which defines the total number of eligible patients for breast cancer screening, which is everyone between 52 to 74 years of age. Next is the numerator, women who had one or more mammograms on or between October 1st, 2 years before the measurement year and the end of the measurement period. This is a complicated way of saying that if the measurement year was 2025, then the mammogram needs to be performed between October 1st, 2023 to December 31st, 2025. Then we have denominator exceptions. In this case, people are removed from the denominator only if the examining doctor justifies that it is not medically appropriate. Examples include people in hospice or palliative care, history of mastectomy, patient is 66 years and older and living in a long-term nursing home, patient is 66 years and older and meets criteria for both frailty and advanced illness based on specific ICD-10 codes defined by NCQA. Interestingly, if the patient dies or even has a history of breast cancer, they are not removed from the denominator. Next is the reporting period during which the quality measure applies. This is generally between January 1st to December 31st. And last are the data sources that will be used to calculate the quality measure. These data sources are generally billing codes, or they may involve a manual review of the medical record to find the documentation, which is generally a mammogram report, and submit it to the insurance company. Now that we know the details of this quality measure, let's analyze its rationale and if it's achieving its intended outcome. The current breast cancer screening quality measure is based on the 2016 breast cancer screening guidelines from USPSTF. The screenshot in the slide shows the 2024 guidelines. The difference between the 2016 and 2024 guidelines is that in 2024, USPSTF decided to lower the age of mammography from 50 to 40 years of age. Before we look at the data behind breast cancer screening, we need to define breast cancer. The standard definition of any cancer is uncontrolled growth of cells. But then the next question becomes, at what point in the life cycle do we decide that the growth is uncontrolled? Similar to my last video, we can look at breast cancer from a retrospective lens of natural history of progression of disease or the prospective lens of biologic pathway. From the retrospective lens view, we will assume that any dysplastic abnormal cells is potentially dangerous and can turn into cancer. So, we will try to find every single one of these cells and destroy them. From a prospective forward-looking view, we are forced to ask the uncomfortable question if every abnormal cell will go on to cause cancer, and if destroying every cell will cause more harm than benefit. An example of this dilemma is the diagnosis of ductal carcinoma in situ. These are very tiny abnormal cells found in the breast ducts, and there's a lot of uncertainty on what to do with this diagnosis. Now let's look at the United States Preventive Services Task Force, or USPSTF guidelines on breast cancer screening, and the underlying data for their Grade B recommendation. I'm going to show you screenshots of published information from the 2024 guidelines and the 2016 evidence synthesis document with my explanation on the next several slides. This slide shows data from the USPSTF guideline documents. The relevant numbers are below the screenshot. The relative risk reduction in breast cancer specific mortality is 0.86 for women between 50 to 59 years of age and 0.67 for women between 60 to 69 years of age. All the other numbers in these screenshots are not statistically significant. So on average, there was a 15% relative risk reduction in breast cancer specific mortality. Of note, there was no reduction in all-cause mortality. This is a very high-level overview of the benefits mentioned in the USPSTF guideline document. Now let's dive into the details about the trials that led to the Grade B recommendation. These screenshots are from 2016 evidence synthesis document that USPSTF used to make the decisions. No trials met the criteria for good quality randomized controlled trial, or RCT. All RCTs were fair quality, and USPSTF excluded poor quality trials. None of the RCTs were designed to evaluate screening intervals. And this document admits that these fair quality trials may not be applicable to today's current population, as all the trials were conducted at a time when imaging technologies and breast cancer therapies were very different. Another important limitation is that, in general, people who enroll in trials and attend screening interventions differ from those who do not. In this case, women at high risk of breast cancer but lower risk of all-cause mortality may choose to participate in screening. This important bias gives the illusion of benefit to all screening programs, including breast cancer screening. When the trials compared mammograms done every 1 year versus every 3 years, it showed no difference between rates of breast cancer mortality, size of the cancer, or if it had spread to other organs. The decision to lower age of breast cancer screening from age 50 to 40 was based on data modeling, not clinical studies. Now, I'm not going to go into detail of data modeling, except that when you perform data modeling, you have to start with a lot of assumptions. An example of this assumption could be that breast cancer in a 40-year-old woman is equally aggressive and as likely to cause death as cancer in a 70-year-old woman. We know that this is not correct. Breast cancer in younger women is unfortunately more aggressive. Therefore, when performing data modeling, we have to remember that garbage in equals garbage out. For those of you who are wondering about the role of breast ultrasound and MRI, unfortunately, there's no evidence of any benefit for these tests for screening. As a reminder, I'm talking about imaging tests for screening, not diagnoses. The benefits far outweigh any risk when these tests are used for diagnostic purposes. Therefore, in summary, there are no high-quality randomized controlled trials for breast cancer screening, no good data on the interval for screening, and digital mammograms that we use today are much more sensitive with a much higher false positive rate than 11 to 19% in the old studies. My goal here is not to discourage people from getting mammograms, but to highlight the data. Mammogram is just a tool and can provide tremendous benefits when it's used appropriately, but can also cause a lot of harm in the hands of NCQA. So now that we've looked at the data behind breast cancer screening, let us look at the harms of screening, especially when it becomes a quality measure. The first is false positives, which we touched on a little bit before. False positives are artifacts on screening tests that are found to be normal after additional workup. That is, the person is not diagnosed with breast cancer. ACOG, or the American College of Gynecology, does a better job highlighting the false positives than USPSTF. Per ACOG, 10-year cumulative false positive rate is 61% with annual screening, leading to a 7% biopsy rate. With biennial screening, the false positive rate decreases to 42% with a 5% biopsy rate. Furthermore, dense breasts increases the risk of false positives. Also, once a biopsy is done, the chance of a false positive rate increases in subsequent mammograms and also possibly increase the risk of breast cancer itself. Next is overdiagnoses. Overdiagnoses are artifacts or lesions detected on screening that after additional workup look like cancer. The person is diagnosed with breast cancer, but there is no improvement in life expectancy. This slide is from my prior video, False Positives, Real Profits, depicting how overdiagnosis bias works. To learn more about biases in screening, I would encourage you to watch that video. Between 20 to 50% of screening detected cancers represent overdiagnoses based on patient's age, life expectancy, and tumor type. People that fall in this category undergo some form of treatment, ranging from watchful waiting, chemotherapy, to mastectomy, for a disease that would not have made any difference to their lifespan. Furthermore, these women often believe that screening saved their life. Screening mammography uses ionizing radiation, a known carcinogen. While the radiation dose in each exam is very, very low, exposure is cumulative. We don't have good data, and most people agree that the risk is minuscule. Keeping the garbage in, garbage out theory of data analysis in mind, the data analysis does show that 2 to 11 cancers per 100,000 women will be due to mammograms. Now, this should not scare anyone who needs a mammogram because the risk is minuscule. The point here is there's no free lunch. Then we have challenges with resource allocation and access to care. Radiologists are limited in availability, and the time spent interpreting screening mammograms could be better utilized for reviewing imaging studies of symptomatic patients. How often have patient discharges been delayed from the hospital due to pending radiology results? Here is a screenshot from a Google search that I did showing the advertising related to breast cancer screening. This relentless advertising promotes fear, hope, and the misconception that breast cancer screening saves lives. This is further compounded by making breast cancer screening a quality measure, which disincentivizes doctors to fully inform patients about the potential risks of screening, as patients who decline breast cancer screening will negatively impact the physician's performance metrics, penalize them in value-based contracts, and increase their malpractice risk. Now that we understand the risk of breast cancer screening, let's take a look at what PCPs and ACOs can do to meet the measure. When a person is sent for screening mammogram, radiologists need to use the appropriate CPT and ICD-10 codes to bill. If the insurance rejects the claim, or the person switches insurance companies, your humble PCP is still held liable and penalized. If the patient qualifies for a denominator exclusion, example has a history of mastectomy, then the doctor such as PCP, oncologist, or surgeon must bill the appropriate CPT and ICD-10 codes during an office visit in the measurement year to remove the person from the denominator. There is one CPT2 code for breast cancer screening. Once CMS switches to the Electronic Clinical Quality Measure or ECQM, this will not be accepted. Supplemental data submission involves finding mammography reports and submitting them to the insurance company. Manually collecting and submitting denominator exceptions is a complete mess, with every plan creating its own rules on what it will and will not accept. Artificial intelligence can help find the supplemental data and collate it for submission to the insurance company. However, this benefits large organizations with a single EHR at the expense of small PCP practices. Given the data, the best conclusion is that we have no idea how many, if any, people will benefit from screening mammography using the modern digital tools, and a small but unknown percentage will be harmed. Most modeling studies, such as those using the CISNET database, are based on our assumptions and biases that we feed into these models. No wonder all these models show that mammography saves lives. Since there's a huge demand and almost religious belief in mammography, we badly need new trials to assess the efficacy of mammograms for breast cancer screening. While we wait for the new trials, ACOG has the best recommendation for breast cancer screening. Shared decision-making is particularly important for decisions regarding breast cancer screening because many choices involve personal preferences related to potential benefits and adverse consequences. Making breast cancer screening a quality measure is an excellent way to undermine shared decision-making and informed consent. You can find a written version with references to the material and audio podcast version on PCPLens.com. If you like this video, please sign up on PCPLens.com so that you don't miss the next episode when it's published. Thank you for watching this video. Take care and goodbye.